Our next speaker is Dr. Naresh BABU. He's a director of vitreoretinal services of the Arvind Eye Group at Madurai. And he's going to talk to us about management of PVR uh, following trauma, basically traumatic PVR management.
It's on. Okay, check. Okay. Thank you very much, sir. Thank you for making me a part of this IC.
Thank you.
And I am very happy to see a full hall, actually, which is a very rare sight nowadays. So, in this, we'll be basically discussing few of the tips what we do in case of traumatic PVR. But there will be certain repetitions. Please forgive me, and those repetitions are nice to remember. Okay. So, in case of trauma, so PVR is very high actually. It is as high as 45 to 85%. So the importance of this is like in case of traumatic RDR, vitreous hemorrhage or whatever, where we go for surgery. The important thing we have to tell the patient is no surgery, no patient is going to be cured with a single surgery. So usually in all the trauma cases, we counsel in group and we tell that the patient may even take 10 surgeries also. It is very hard for the patient to, and the attenders to digest, but we have to do that. Okay, so the onset also varies. It's not immediately we'll come across PVR in case of trauma. So depending upon whether it's a perforating injury or a rupture or a foreign body, it ranges from a minimum of 1 month to a maximum of 6 months for the proliferation to happen in these cases. But when they proliferate, it is very severe. And these are the factors, and some, as I told, some will be repetition. Usually in any case of PVR, not necessarily in trauma, wait for the membranes to mature, because if you are going to operate on a immature membrane, it's very difficult to remove. The membranes are very slimy. So we always wait for 8 to 12 weeks. Even if the macula is off in case of trauma, no issues. Once the macula is off for a longer time, it's fine. It doesn't make much difference. Wait and then operate. So the goals has been discussed extensively. And the pre-op evaluation is important. Like in case of intraocular foreign body, mostly the patient will come with only the ocular trauma. But in case of a road traffic accident, there will be other collateral damages also to the rest of the organs of the body. So we have to take into consideration the general condition, and all our trauma cases we operate under GA because we cannot tell how much time we'll be taking. And of course, if the patient is having a single eye or if both eyes lost, there is no way we have to operate in these cases. And the most important is in case of trauma, no PL is not a contraindication, because a lot of people with no PL will improve, and this has been discussed following surgery. So for membrane dissection, which is the important part, we have to go with the right instruments. Be prepared for the instruments which you have. And there are many ways of removing the membranes, which has been already discussed. Subretinal membrane and the napkin ring, usually I go subretinally, that is through the sclera, 10 millimeters posterior, but in this case, that video is not there, because in case of trauma, I usually don't prefer that. The reason is in case of trauma, the alteration in the anatomy of the eyeball makes us difficult to go subretinally. So we go for the conventional technique of making retinotomy. The importance of this is using the right instrument. Go for the max grip, because the instruments sometimes may not completely pick. And we need to do multiple retinotomies also in these cases. And don't chase all the membranes, even if they are snipped, it is fine. Retinectomy is very important. These are the indications where we do the retinectomy. The most important is the extent of the retinectomy. When we are doing retinectomy, at least 180 degree has to be done. And prior to that, we have to do a diathermy so that there is not much of bleeding. And as a rule, for myself, I don't do retinectomy in the first surgery. Because when we do retinectomy in the first surgery, and if you're not peeling the membranes, the proliferation is so severe that it leads to something called severe intraretinal proliferation. So we reserve that for the resurgeries. So this is one of the case with PVR. So you can see the inferior retina is detached. So by injecting the PFCL, we can make the peripheral retina pullous And using a diathermy makes the thing avascular. So make a nice diathermy for 180 degrees. Then we can use the cutter to cut. And there are various modalities, types of this thing, cutting. Like usually we go for a linear proportional cutting, but I always use proportional vitrectomy, where we have a separate control for the vacuum and the cutting. So you don't need to switch off the cutter. So nice, we can do a nice retinectomy. And I am very liberal in using the dye so that we can see the membranes, and after that it has to be treated like a giant retinal tear. So we'll just, this is very important because we use PFCL very extensively, and so Gopal sir was telling about putting the what you call band or the suprachoroidal steroid. But in our cases, we found that PFCL as a short-term tamponade, we keep it for 10 days, both as in this case as well as in cases with what you call choroidal detachment. We found this to be very useful, because in case of choroidal detachment itself is what you call promoting factor for PVR change. But if you retain the PFCL, how much ever choroidal detachment it may be, we cannot see even a single mount on day one. By 24 hours, the complete absorption of the choroidal detachment happens, and thereby actually the proliferation is much lesser when we are using a staged approach in case of RD with CD. So we'll go for some of the surgery. This is a bilateral blast injury. One eye is thicical, the other eye had a K-Pro, and then the patient developed dense membrane. So we have done a membranectomy behind the K-Pro. The problem with these cases is the anatomy is altered. We don't know where to enter. Sometimes we might enter directly. But fortunately, I had a retinal detachment, not much of proliferative changes, only the pre-retinal membranes. And they were all mature and easily identifiable. And as I said, in most of these cases, we go for a stage surgery. Once all the membranes are done, we peel the ILM also. And as was shown by Dr. Ramandeep, you can find the thin sheet of vitreous also. So once it's all done, we retain the PFCL for a week or 10 days. And usually I don't do the laser in the first stage, because after 10 days, usually the retina gets very well attached and the laser uptake is very good. And in most of these cases, we peel the ILM by ensuring, by doing this, we ensure two things. We remove the vitreous, as well as in most of the cases, the proliferation, epiretinal proliferation after the surgery is avoided. So once if you inject, this is the end of the first stage, and then we go for the second stage where we replace that with oil. And this is after 2 months. The BCVA is 5/60, and that is fairly good enough for the patient. So this is another case with, again, a history of trauma with a corneal tear. The problem is there is incarceration in the periphery and a lot of PVR membranes. So usually we do a nice retinectomy at the site of incarceration. Otherwise, how much ever surgery we do, usually it goes for the resurgeries. It's not very clear. So this is after 3 months, the patient has 6/36 vision. And this is another case with closed globe injury with the vitreous hemorrhage. Blood is another important thing which leads to proliferation of membranes. So this case actually, again, most of these cases are single-eyed. You can see a completely crumpled retina. The important thing I would like to emphasize is when we are doing all these complicated cases, two things we have to do. Better post it when you are on a leisure day, number one, and number two, switch off your, what you call the clock, or turn the clock in the OT room. Don't bother about the timings. And as I said, most of these surgeries are done under GA because we don't want the patient to shout after some time. Okay, so as was told earlier, TANOS is a wonderful instrument. So that helps in basically identifying the membranes also. So we have to dissect all the membranes and we retain the PFCL. And this case had some 1/60 or 2/60. And this is another case of a trauma. As I said, we have to switch off. This is a condition actually. The patient came much later with a complicated cataract, which was done. So extensive membranes. Usually if the patient's other eye is good, We don't bother to touch these eyes because 1 by 60 or 3 by 60 may not satisfy the patient, and our time is also extensive. But if the patient doesn't have, we have to operate. As I said, don't bother up to the time. Take take your own time, be patient. So I was fortunate enough to get the plane of the membrane in these cases. Once I could open, then we injected the PFCL. So it's like that what you call Kajal's advertisement, soupy noodles, Kao, Pio, like that. You just inject, then peel, then inject, then peel, so that the membranes also gives way. So we kept on peeling, and this is at the end of the surgery. Yeah. So after the second stage, we removed the oil, and it is hard to believe that this was the case actually. So it took a longer time, but it was sometimes very gratifying. So this is the same patient after 2 months with a 2 by 60 vision. And this is the most important, I'll skip this for want of time. This also I'll skip for want of time. I'll just go for the last case. So this is another case, 46-year-old gentleman. When we refer the cases to our orbit colleague, I hope nobody is there, they usually go for enucleation in these cases. But now it is easy for us to manage sympathetic ophthalmia, so we usually resist going for this thing. This is a case with a flat tire sign, you can see in the CT also. We said, okay, we'll repair. So I don't have the, the video of the first surgery. We have done the AC reformation, scleral suturing was done. And slowly the eyeball improved. And this was after 14 or 15 days. Then we went, this was the status. So the patient was aphakic with a sutured scleral wound as well as the corneal tear. When we went inside, it was a bit bad actually, but still, where is it? Inside it's not there, okay. Now we have retained the PFCL as I told for 14 days, 10 days, and then we reoperated. And this was the final outcome of this patient. So the patient's vision was again 6 by 60. We don't expect much. So methotrexate in PVR is very, very useful, and we have our own in-house publication, but it's a very small number. But we found that injecting methotrexate is very useful in these cases. We go for at least a 4 injection weekly interval, 400 microgram, and usually the oil is removed at the end of 3rd month. And one additional thing is what we have found this to be useful is, which is under public, review now, is in subsilicon oil hemorrhages in case of diabetics. We found this methotrexate, literally enhancing the absorption of the hemorrhage. So we don't have any AC, shallowing or any raised IOP because of subsilicon oil hemorrhage because of this drug actually. I'll not say it's a wonderful drug, but definitely it makes a lot of sense. So we had only 20 and 23 cases overall. So we use 400 microgram and weekly interval, as was discussed by Gopal sir. It's a very safe drug because this was used as a first line in case of all intraocular lymphomas, and its safety has been proven already. So we can use it, no issues. And we found that the redetachment is much lesser in the injection group compared to the control group. So in summary, actually traumatic PVR is almost 45 to 70, 85% of the cases, quite advanced, and it is sometimes annoying actually when we go inside. Second thing is no PL is not a contraindication in treating any traumatic cases. So the PVR is a major cause for the failure in this case. So we have to go for a complete dissection of the membrane as well as relaxing retinectomy whenever needed, but not in the first surgery ideally. A short-term tamponade of PFCL really helps, and finally methotrexate in a dose of 400 and a repeated injection really helps us to get fairly a good outcome in these cases. Thank you very much.
Thank you very much, Dr. Naresh Babu, for a wonderful presentation. I request Professor Dr. Bhatti to present the memento to him. Sir, Dr. Bhatti.